And then I was like, maybe we need some
All right, ready? So this is the journal club today is for anesthetic management of emergency endovascular thrombectomy.
We got a neuro fellow coming.
There are the two journal articles that I think were sent out a couple weeks ago. Hopefully people had a chance to take a look at them. But there's part one, which is patient characteristics, determinants of effectiveness and effective blood pressure on outcome. And then part two, they go through some observational reports and some randomized clinical trials. So they start out going through some of the epidemiology and history. So strokes are pretty common in the US, they're 795,000 yearly. It's the fifth leading cause of death. And the vast majority of them are ischemic strokes. And then they talk a bit about the development of the use of TPA. So initially in 95, it was shown to be effective if given within 3 hours of the stroke onset. And it continues to be standard of care today for acute ischemic strokes. However, there are a lot of patients who are excluded from getting it, like if they've had a recent major surgery, and then even if it's given within the efficacy window, you may not get complete clot lysis with it, and it's thought to only be helpful in about a third of patients who receive it. And in particular, it's bad for larger clots that are in more proximal arteries, and so that was kind of the impetus for developing mechanical removal of these clots. So the first generation devices, they put out some studies not even that long ago in 2013, and at that time those devices were not really showing improved outcomes, but they've developed them a lot over the last few years. And in 2015 they started coming out with some articles showing that these newer generation devices have doubled the percentage of patients with little or no long-term functional impairment. And so the 2018 AHA stroke guidelines are for giving a thrombectomy as standard of care for an anterior circulation stroke within 6 hours or up to 24 hours with certain criteria, which is from these two trials. One's called DAWN and one's called Diffuse 3. And in DAWN, they did thrombectomies up to 16 hours, and in Diffuse 3, they did it up to 24 hours after presentation of a stroke. And in those studies, they were using these advanced imaging techniques like CT perfusion and MRI, and they were looking at patients with a small ischemic infarcted area and then a large penumbral region that was still viable, and they found it to be helpful up to either 16 or 24 hours in those patients. And then the effectiveness in the posterior circulation strokes hasn't really been established, but they are doing some randomized control trials on that now, and the article was saying it seems like it's going to be a favorable outcome, so they're probably going to start doing more thrombectomies in those patients. So I included this since we're becoming this stroke center now. These are the requirements. So you need immediately available diagnostic and therapeutic services, sufficient case volume, which is just 30 thrombectomies a year, and then the time from arrival to imaging, you want less than 30 minutes. From imaging to arterial puncture, you want less than 60 minutes, and then from arterial puncture to the first attempt of the thrombectomy, you want that in less than 30 minutes. And so this kind of shows you why there's always such a rush in trying to get things going. There's a lot of time limitations. So then they go through some of the characteristics of the patients. Their mean age is 66 plus or minus 13 years. They have a lot of comorbidities such as hypertension, AFib, diabetes, previous strokes, coronary artery disease. Many have had TPA, and most are at least moderately hypertensive at presentation. And then just for reference here, the National Institute of Health stroke scale, it goes from 0 to 42. A patient with hemiparesis has a score of 8. Most of these patients have a score of at least 10, so typically they're relatively significant strokes that are coming for thrombectomy. So then they go through the determinants of effectiveness, so age, their NIHSS score, the time to reperfusion, the location of the clot, their collateral perfusion, and then achieving adequate reperfusion are all determinants. This chart here goes through how they rate adequate reperfusion, and you want at least a 2B, meaning greater than 50% reperfusion. And so an increased age and a worse NIHSS score at presentation are associated with worse outcomes. And then there's decreased effectiveness over time, except for that small subset of people that we were talking about from the DAWN and Diffuse trial. And then in general, occlusions that are limited to the MCA are more favorable versus, intracranial, internal carotid clots. And then I included this Rankin scale, just 'cause I wasn't familiar with it, and they use it on a lot of these studies to sort of rate their functional outcome. And in general, the studies were saying a 2 or less is considered a good outcome. And at 2, it says there's a slight disability, they're unable to perform all of their previous activities, but they can pretty much live on their own. And so that's considered a good outcome. So then in part 1, they start going through all of the issues with blood pressure control in these patients. And they're commonly either acutely or chronically hypertensive or both. And in people with and without chronic hypertension, you do typically see an increase in mean arterial pressure at presentation. This is thought to be an adaptive response to increased perfusion. But then sort of paradoxically, someone presenting with a higher systolic blood pressure has been shown to have worse outcomes. But that being said, we all know you don't want to be decreasing the blood pressure in acute stroke unless they've had TPA, and the guidelines with that is to keep the systolic under 180, because then you're starting to risk hemorrhage at that point. So they've done some imaging studies where they look with angiography, and the reason that you don't want to decrease the blood pressure is, of course, to keep up perfusion to that penumbral region that's at risk. And they've shown with even a decrease in MAP of 10, you can start getting decreased perfusion to that area. So then the NIHSS score at presentation does correlate with the collateral flow status. So you would expect that the sensitivity to decreased blood pressure might differ based on their presenting NIHSS score. And people with lower outcome or lower NIHSS score would have a better outcome and be less affected by blood pressure changes. And that was the case in some studies, and they include this in part 1. So they're showing a rate of good outcome, meaning that Rankin score of 2 or better. And then they divide it up based on the NIHSS score at presentation and the MAP during the lowest MAP during the thrombectomy. And so at a score of less than 15, they had the best overall outcomes, and it wasn't as effective by changes in the mean arterial pressure. And between 15 and 20, once the MAP got less than 70, you started to see a big drop off in terms of functional outcome. And then at an NIHSS score greater than 20 is when the MAP started to be affected at less than 80. But then in general, overall, between the 3 groups, they had the best outcomes when the MAP was over 90. So that's pretty much it for part 1. It's a little shorter. And then part 2, they start going through some different studies. They did a literature review up until April of 2018. And they were looking for studies that were comparing sedation for these cases, which means either local or getting some form of sedation versus general anesthesia. And they were looking at studies that compared the neurological outcome, mortality, the workflow issues, and complications. And in all of the studies, general was not found to be superior to sedation. But then the thought was that these older studies tended to overestimate the negative effects of general anesthesia, because there were some issues with the studies, like any patient that came in intubated, even if they were intubated by EMS in the field, was considered general anesthesia. So those are obviously severe patients to begin with. Anybody who was converted from sedation to GA was considered GA. And then in a lot of the studies, they didn't discuss like what meds they gave or what, even what vasopressors, and some of them didn't even report hemodynamics, and the blood pressure control is obviously very important. And then some didn't also standardize the hemodynamics, as we'll get into with some of the randomized control trials. They had standard, you need to keep the systolic over 140, for example. So the author said, accepting the limitations from the observational reports, that they found these risks to be associated with unfavorable outcomes in those studies, a greater NIHSS score, having an intracranial internal carotid artery occlusion, and then posterior circulation strokes were all associated with worse outcomes. Then this table is from part 2. Looking at the observational reports that were statistically adjusted, looking again at the modified Rankin scale of less than or equal to 2, meaning a good outcome. And they took the natural logarithm of the odds ratio with it over 0, meaning that neurological outcomes were more favorable with sedation. And you can see that over time, the benefit of sedation over general anesthesia got less and less. And that was a statistically significant number at 0.009. Based on the observational studies, the authors make these 7 hypotheses going forward. So first is that general anesthesia increases the time between the decision to perform a thrombectomy and reperfusion by 20 minutes. Then that outcome differences between sedation and general are due to blood pressure differences. Next is that the sedation patients receive less vasopressors. Then the majority of sedation patients who are converted to GA are done so because of agitation. That general may actually increase the incidence of good reperfusion, but the difference is likely too small to detect. General may slightly decrease the risk of complications due to decrease in movement, but the difference is probably too small to detect. And then the last one is in regards to stroke-associated pneumonia, since it's related to the NIHSS score, that the greater incidence of pneumonia in the patients who got general, it might be a selection bias. So then they start going through these 3 randomized control trials that looked at sedation versus general. It was, the first one is sedation versus intubation for endovascular stroke treatment, or siesta, then anesthesia for stroke, which is anestroke, and then general or local intra-arterial therapy, or Goliath. And there was a lot of heterogeneity in these 3 trials in terms of good outcome, but none of them really showed that sedation was a more favorable form of anesthesia than general. And I'll show the chart on the next slide. And all 3 of these trials, they had similar blood pressure like delineated numbers that you need to keep of at least 140. So this first table, so this is just looking at the functional outcomes and mortality. So the incidence of a good outcome with sedation was 18 and 40 and 52% in the 3 trials, and then with GA was 37, 42, and 67. But a lot of these numbers were not statistically significant. And they took a pooled relative risk in terms of the functional status, and that was 0.74. And with the relative risk being less than 1, that would mean a good outcome in functional status may have been less common in patients who got sedation rather than general anesthesia. But again, it wasn't significant. So we're saying that there's really no difference that can be stated in terms of general versus sedation for these patients. Then the next table, they compare the hemodynamics in all 3 trials, and many patients in both the sedation and the general groups required vasopressors, but in all 3 trials, the patients who had general anesthesia required much higher doses of vasopressors, 1.5 to 3 times higher than the sedation patients. And then in addition, in 2 of the 3 trials, the patients who had general were much more likely to have a decrease in blood pressure of greater than 20% from the presentation mean arterial pressure, even though they had those well-defined blood pressure goals. Then the next one, they look at the workflow issues between sedation and general anesthesia, and there was a bit of a delay in the patients who had general anesthesia, but it was 10 minutes or less, and the authors state, that's kind of an acceptable time you would expect for someone to be inducing general anesthesia. But then once they made the arterial puncture, it was a faster time to reperfusion in the patients who had general anesthesia. It was numerically less, but not statistically significant. And then in all 3 studies, the reperfusion was numerically greater in the patients with general anesthesia, but again, it was not statistically significant. And then the last table that they put in there is looking at the complication rate for these patients. And depending on the trial, it was between 6 and 33% of patients who had problematic movement during the procedure, but it didn't seem like that really caused any significant vascular complications from the movement. And then between 6 and 16% had to be converted from sedation to general anesthesia, and typically that was for agitation or airway issues during the case. And then they also go through delayed extubation, which was defined differently in each of the trials. In one, it was they were still intubated for 2 hours after. One was just if they're intubated after leaving the IR suite, and the other one was after 16 hours. And for some reason in Siesta, which defined delayed extubation as for 2 hours after the procedure, they had a much higher rate. 49% of the patients who had general were still intubated versus 7% and 3% in the others, and they're not exactly sure why that one had such a high rate of delayed extubation. So then the authors make these conclusions based on those 3 randomized controlled trials. So they state that when the blood pressure is kept the same, there isn't really a difference in favorable outcome between general and sedation, that the delay is 10 minutes or less, and that you typically need higher vasopressor doses if you're going to do general, have less movement, and quicker time to reperfusion. Then they talk about some of the limitations with those 3 randomized controlled trials, one being that they're all single center, they're protocol driven, written by some neuro anesthesia experts, and they're not sure that they can be reproducible. And then also a big number of patients were not randomized into the trials. If you combine all 3 of them, up to 40% were not randomized. And some of them were not because they were a poor sedation candidate, like they were vomiting or something on arrival or very agitated, and then posterior circulation strokes were not randomized. So the last part of the journal article, they're going through just sort of some decision making and some considerations to think about when you're taking care of these patients. And they say that there's no current evidence-based algorithm that you can use to decide who needs general versus who needs sedation. And then as a lot of us have experience doing these cases already, there's a really big emphasis on rapid workflow. A lot of times you won't have the medical record when the patient shows up, and they may be confused or even aphasic, and you can't get a lot of information from them or a good history. So they give this rapid assessment that they think is helpful when you're evaluating these patients. First is, are they responsive to verbal and tactile stimuli? Can they lie supine without having any respiratory distress? Is their SAT acceptable, which they said in the article is 94%? And then can they follow commands? And then thinking about if you were to have to convert from sedation to general in the middle of the case, do you feel like you could manage the airway under non-ideal conditions? Next, they talk about some other issues with the patients, and remembering that they're often coagulopathic because they've received TPA, so you want to be careful if you're going to put a nasal trumpet or something like that where you can actually get a pretty significant nosebleed. There's no evidence in any of these studies that different meds are better than others, including your sedatives, your vasopressors. They talk briefly about ventilation, and that you would assume, of course, hyperventilation is not going to be helpful in these patients because you want to have good perfusion, and so they say maintaining normocarbia is reasonable. And then there were some observational reports in stroke patients who were intubated that if they were hyperoxic, they have less favorable outcomes, and so they said to consider decreasing your FiO2 to maintain a SAT of above 94 if it's safe for the patient. Then they also talk a bit about the extubation criteria and how that might be different in these patients because they're already coming in confused. So they looked at some observational reports of middle cerebral artery stroke patients in the ICU, and in general with extubation, They found that people who were spontaneously opening their eyes rather than just opening to speech or pain did better with extubation. And then they very briefly touch on A-lines, which I know is something we've all, discussed doing these cases. So in 2014, there was these guidelines published by the Society of Neuroscience and Anesthesia and Critical Care, and they just said an A-line is useful if it's not going to delay the procedure. And then the authors of this journal article said they don't routinely use it. They try to use a femoral A-line if it's placed by the IR doctor, and then just cycle the cuff frequently. And then if you think they're going to need it for post-operative care, to put in it at the end. And then they give a few recommendations at the end, stating that you should favorably consider the interventionalist recommendations, that they might know if the procedure is going to be easy, and they might have different tolerance levels for the patient to be moving. And even though they made all of these arguments that general is not worse than sedation, they still think that sedation should be the default anesthetic method unless there's a clear indication for general anesthesia. And then I just put in this quote from them. They said the best current evidence indicates that when accomplished with rapid workflow and maintenance of blood pressure, GA is a reasonable option for patients treated with endovascular thrombectomy. And so that's pretty much all of the information from the articles. I just put in a couple potential discussion points if people want to talk about their experience with these cases. Is there anything here that would change your practice, or if you have any thoughts on sedation versus general? I know we pretty much always do sedation unless they're already coming in intubated. Any issues with the workflow and assessing these patients, or arterial lines. I was not at the meeting with Dr. Lopez recently. I think that was probably brought up, but if anyone has any thoughts or comments or questions.
I haven't done one of these yet. Is the clear site down there?
Clear site is down there,
So
but no one ever uses it.
There's
But you
already-
can use it if you want to. I think it's a good idea personally, but
Are
you
there
know, you
nice
gotta get
instructions
set up.
on it, how to turn it on? I usually get to it, but that's a problem. And do most people sedate with propofol or just to be
Nothing.
a little
It's
versatile?
usually nothing.
Fentanyl,
Nothing.
fentanyl.
Yeah.
Just standby?
Yes.
Yeah.
Oh, you should give nothing.
I mean, if they're having a stroke, they're pretty sedated anyway.
They're not wiggling around too much?
And that's when you give, in my experience, I've had it gets a little propofol in the middle sometimes nothing, sometimes 1 milligram of Versed. But if I have the propofol in line, I turn it on if I need it, but they tape them pretty strong and they're pretty much unconscious.
And they maintain their airway? Do you have oral airways in or LMAs or anything like
I've
that?
only done about 4 and they've all been, they maintain their airways fine.
So basically that's as well as you.
Yeah, and pressure, you have to manipulate the blood pressure, but I didn't even have to do that because they're naturally a little hypertensive when they're having a stroke, and that's what they want them at.
He likes the one above 140? Is that where we want?
No, he wants him to be like permissively hypertensive to whatever. I mean, I've seen the neurologist say that up to 240 over 120 is
Okay.
acceptable, so they just wanna like pound blood through those tight occlusions any way they can. I mean, you're not artificially bringing it up, but you're allowing it to go basically as high as it will.
What are you doing with the fluid status? Are you just?
Oh, one thing about that is if they got TPA though, they want, you don't want it to get over 180. So that might be a situation where slaving off of the groin femoral line that they put in, or just putting an A-line in yourself might be of value. But, you can try to do, it's kind of hard to do it while he's working because, you don't want to be sitting there absorbing a bunch of radiation. So he's offered to let us transduce his femoral line, but it seems like no one's ever asked him to do it, so.
I've done it. I've done it. It
Yeah,
doesn't
he's not
work that well.
he's not gonna
It's not
volunteer.
effective, it's a dampened art line.
Because he's got a
Yeah.
catheter.
Yeah.
So I think if you're gonna use an art line, you might as well just put your own in. But it sounds like, based on these studies, they're saying that non-invasive blood pressure
Yeah,
is reasonable.
It's reasonable if you're saying
And
they
the
just
clear
cycle
side is a
frequently.
really good option.
I think if we got the literature to back up not using an A-line routinely, we probably should follow that because, you're just
The
slowing down the
minutes.
process. The main thing is to get the case done quickly.
Right, I think you can do an A-line as long as you don't tell him to wait for you, just work while he's working.
Yeah, but you can do it
He
fast.
doesn't seem
You
to
don't wanna
like
hold the
that,
case
like
up.
he thinks it's gonna make them move too much, I think.
Problem is they immobilize the arms and their restraints are right at their wrist.
But we need an A-line for ICU, correct?
And when he's done, you put it in.
I've taken them up,
Soon
I've
done
done
it
it
afterwards.
You don't have to put it in.
Aren't they watching blood pressure very carefully up in the ICU?
Yeah, but they don't put A-lines in anybody up there.
Yeah, a lot of them go to the NICU.
They run.
They run pressing
They run,
on cuffs,
yeah,
so.
exactly.
Well, does he take his arterial sheath out at the end?
Yeah, I think he does. I think he puts one of those angio seal things.
If you
in
were
there.
really concerned, you could just leave his sheath in and, he has a femoral line, arterial line to do the procedure. You could just transduce that. And if somebody was really unstable, put in your own or else, or just use that one and have them take it out upstairs, but I haven't seen that happen yet. The clear sight's a great idea, she doesn't know how to put it on.
Where is it
It
downstairs?
takes a little bit to
No,
calibrate.
I talked to
and set up.
Jonathan about, educating the staff down there, but that's gonna be a process,
Right.
obviously. Resistance is the knee-jerk
No, but that
reflex.
would be ideal, because you're
I
not
thought
worried about
Columbo
blood
insisted
sampling.
on it being, I thought he was the one that.
And again, they usually take about a half an hour, it's not a.
Not very long.
Yeah.
What's the update on the NICU, NSICU, neurosurgical ICU? Is that, it was supposed to have been open by now?
The NICU is gonna happen, it's supposed to open on June 1st, but it'll probably be July 1st and then August 1st.
Do they
It
have?
started out April 1st.
Yeah, right, so do they have, intensivists hired?
Right. So they've got this guy named Neon Urfi, who's a very nice guy. He looks like a deer in the headlights at this point, because I think he has no idea what he got himself into. They have another neurointensivist signed up for, I think, September or October. I think coming out of a fellowship or perhaps just another institution, and they're looking for a third. Trying to get PAs and neuro ICU nurses. It's, the staff, they just can't hire people fast enough, and that could be the rate limiting step to actually opening this thing up, because Urfi seems like he's overwhelmed.
How many beds?
9.
Wow.
And, they haven't chiseled in stone what kind of cases are gonna go up there, but, the thinking is all the strokes and these neurointerventional cases are gonna go up there, and the spines and the cranies. I mean, the cranies maybe will go there, but, at this point, those are still going to the SICU and the spines. So, big surgical cases still go to the SICU, but they want the strokes, the non-interventional strokes, all that stuff that basically takes up bed space, clogs up SICU. They want that stuff in the neuro, and
How many interventional strokes are we doing right now? And is there a goal, how many they think we're going to be doing?
well, there's something called the PCC, the Patient Care Command Center, and this is pulling in like a, so say at Sherman, their ICU, somebody there's a stroke alert. They can't handle it there, so they call the PCC, and they will transport the patient to the nearest place that's got an open bed. And pretty much they don't say no to anybody here, so it's gonna go to the closest stroke center. And we're not the only one in Advocate. There's us, Christ, Good Sam, and I believe Masonic. So, and then they're all the way up through the whole Aurora system. I think there's 12 of them. So there's this big line of transport. and then they decide whether it's gonna be by land or by air. And so eventually we're gonna be getting this app called Join, which you can put in your own phone. What I'm gonna push for is something from the company that the call person can carry. It'll tell you, you know, from the moment of basically the phone call to transport, all the way through transport. You can follow this moving dot all the way to your ER. And as that goes, there's also a rolling text messaging of as information's acquired, it gets thrown on there, even scans get put on there. So, you know, instead of just walking in there with zero information, you're gonna have a little bit of information, but you're never gonna have a lot of information. You know, we're just gonna have to, you know, get used to going in on these cases with very little information, and basically they want us there in case the patient crashes and we have to intubate, or if they're already intubated, then, you know, we do a general anesthetic. And, you know, under a general anesthetic, that might be the situation where it would be reasonable to put an A-line in, but, you know, everything's a case-by-case basis. We have a neuro anesthesia fellow graduating the end of June, coming in July. Her name is, what is her name? Krista Peters, right? And
From where?
from UIC. She's Jenny's roommate from med school, and she's already established. She's already written like protocols on everything you can think of related to this. So she'll be bringing that with her, and you know, I assume we'll be laminating all that stuff. I asked if I could have it. She wouldn't let me have it. So.
Copyrighted.
I might be able to get it.
Well,
for
she
you
would,
later.
but it was just like, it was kind of an uncomfortable moment, so it's like, she hadn't signed the contract yet, so. But,
There was talk of merging our stroke care with Evanston, the North Shore.
wait, before everybody disappears, IDPH is supposed to be here next week, Monday through Friday, 25 auditors, going through this whole hospital with a fine-tooth comb. You know, I know it hurts everybody to hear this, but they don't want to see open laryngoscope blades between cases. The anesthesia techs are going to be continuously rounding through L&D, main OR, ASC, GI lab. I know everybody wants to make sure that the thing works, but I can't remember the last time one didn't. To be honest.
So we can't have it with paper, have it connected with the covering on.
If you're in a case, but if it's between cases,
You can't even be,
that's.
the package can't be open.
No. I know it's ridiculous, but these are the policies they.
Okay.
Just
they
keep
live
it in your
by.
pocket. Open it, use, and then put it in your pocket.
That's a great idea. That's a great idea.
Just in case somebody falls in the hallway.
Just remember to button up.
And pre-op's got to be done in the EMR before you get the patient in the room, so just do it in the pre-op area at the bedside.
Yeah, we just do it. Don't
So
even go to
we'll
those
see.
cats. Do that first. Thank you, thank you.
Thank you, Ashley.
That was really,
Yeah, that was
I mean,
great.
Ash.
Thanks,
Really
Ashley.
good company.